The chair of the Springfield College Physician Assistant program has been tapped for a working group looking at addressing the opioid crisis in Massachusetts. The group is led by the Department of Public Health in Massachusetts and the Massachusetts Association of Physician Assistants. Charles Milch has been working with people with substance use disorder for many years and shared his perspective on how this group will help train future physician assistants.
I'm part of a working group that was put together by Governor Charlie Baker and the head of the Department of Public Health. And it consists of the program directors for the 9 PA programs that are in Massachusetts. There are 9 at this time. And we were called together to put together some competencies for opiate use disorder and prescribing Schedule II substances, which include OxyContin, oxycodone, fentanyl, and methadone, a few others.
So certainly this crisis has changed curriculum at the college level.
Oh, absolutely, yeah.
And you've been in this for a long time. Tell me how it has changed in the last 20 years, would you say?
20 years ago, there was an article in the American Journal of Medicine, and the article was written by a physician, and it talked about how physicians weren't treating pain. And then from that point on, all of a sudden, pain became another vital sign. And everybody was evaluated based on whether or not you treated pain or not, treated pain appropriately,
right?
You know, with enough medication. And that's when I noticed that pain medications were being prescribed in larger quantities, more frequently to more patients. And as time went on, there was this build of or development of more people that were becoming addicted to pain medications. In 2010, I started working in urgent care, and we treated opiate use disorder patients. And I would go home and say to my wife, I don't think anybody knows about this problem. We had over 500 patients that were addicted to opiates. We were treating them with Suboxone, which is buprenorphine with naloxone. It's a combination medication. And the treatment for opiate use disorder has to be interdisciplinary. It has to be more than just prescribing Suboxone. There has to be psychotherapy. There has to be group work. And so we put together an integrative, patient-focused program at Atkinson Family Practice, and we currently have a support group that we meet once a week, and I do that with Peter Wood, who is a psychotherapist and been working in the addiction medicine for probably 30 years.
But in 2010, so now that's a decade ago.
That's a decade ago.
You saw this coming.
Yes.
And it was really not until 2016, maybe, where it really started to, raise some eyebrows?
So it raised eyebrows. First in Vermont, they declared that they had a crisis. And then I think all the states looked at themselves and said, hey, we all have this, and it was a national crisis. There are in 2017, 70,000 patients died of overdose in the United States. That's 130 a day. That's a lot. And so it became a crisis. And Charlie Baker in 2016 put together a working group for med schools. And then they realized, hey, it's not just doctors that are prescribing, it's also physician assistants, dentists, and nurse practitioners. And so then they developed these other working groups to review and promulgate the competencies and agree to include these competencies in our curriculum. And
because
so,
a lot of people have said, hey, listen, this is all because, they're over-prescribing, these medications, and really have pointed the fingers, at the medical field, medical professionals.
Right.
How do you know how much to prescribe? I mean, there must be so much liability involved. How do you know that you're appropriately treating somebody's pain?
So that's a really good question. It's patient specific. And so part of what we end up doing and part of what the competencies are guiding the students on our assessment of the patient and actually understanding that there are more options for pain treatment other than opiates. And there are a lot of other options. One of the challenges is getting insurance companies to pay for those options. And so
what are some of the options that you're talking about?
For example, I have patients that have back pain, and so massage therapy is important, physical therapy is important. Patients have been successful using acupressure, acupuncture, and so there are other options out there that you might need to treat somebody for a shorter period of time using opiates and then move them into some sort of rehabilitation program that you can put together. And the practice that I work with has all of those pieces together, which I really like. It was part of why I like to work there. I work with massage therapists, nutritionists, PT, OT, psychiatry. We all work together. We meet actually twice a month. We meet and we talk about patients, problem patients that we need more consistent interprofessional work with. And we do that, I don't know, I just find that approach is we're much more successful. The problem with the opiate use disorder population, their problem is that this is a lifelong issue. It's similar to having other diseases like diabetes.
So once you're hooked, it's the rest of your life.
Once you're hooked, you need to be vigilant. And it's difficult, and it's a process. And there's, if people slip, a slip is they go back and use, and then they can come back. And the challenge is to try to use those slips as an educational opportunity for them, so that we can work on. So how do we not do that again? How can you avoid that situation where you ended up having that slip? And working with Peter and working with the support group, we have these conversations on a weekly basis. People come in and they say they had this issue, or they had that issue, or they're going to approach a situation that in the past has driven them towards using opiates. And so how do they manage that? And so we work on all of those things. But it's an ongoing process.
And this affects everybody.
It affects everybody, and it's in families. It affects it. Part of what we try to do is to try to help our opiate use disorder patients that have children not pass that on, to break the cycle. And 9 times out of 10, they came from a background where somebody in their life had an addiction issue. And so we work with them to try to help them break that cycle so that they don't pass that on to their children. And so there's a whole cadre of patients that we're going to have to move through their life, help them through their life. And it's an ongoing process. It's not like, oh, you've stopped using heroin and we can you don't need to use Suboxone anymore, have a good life. It's there all the time. It's insidious. And it's dangerous, especially now when they have, if you buy heroin on the street, you don't know what it's laced with. Generally, they lace it with fentanyl or carfentanil, and people die from it. It's a difficult problem.
Are you encouraged by the fact that the overdose deaths are down somewhat in Massachusetts since the attention has been brought to this issue?
Oh, absolutely. I think that I applaud Governor Baker for championing this whole effort, and I support him completely in it. I think that's a major step in minimizing the damage that happens from this crisis. So I think he did a great job. And it's an ongoing task. We have to keep it up.